Now let's talk about genitourinary dysfunctions. Review that nursing process for a child with a genitourinary dysfunction, or disorder, I should say. Assessment of the renal and urinary tract dysfunction. That should be reviewed for you. Things you need to be looking: physical assessment, looking at their health history, especially previous UTIs, retention, pregnancy, STDs, what kind of medications are they on, what's their urinary hygiene, and what's their patterns of elimination like. So refer to box 46.2 on assessing a child for renal and urinary tract dysfunction. And then we're going to talk about labs next. There's all kinds of laboratory and diagnostic tests that we can do. In the previous slide, it shows just one example of how we can do urine collection by bagging them for urinalysis or a urine culture. There's lots of other things that we can do. I'm not going to go through all of them. I'm going to talk about two specific ones. One on this slide, which is called a VCUG, and the next one is an IVP. These are two different types of X-ray studies, and a VCUG is what's called a voiding cystourethrogram. And what it does is it's looking at the lower urinary tract, and it reveals the structures of the urethra and the bladder, and if there's any presence of reflux into those ureters. So we tend to do the VCUG probably pretty more commonly in kids than you would see in adults, because it goes with one of the disorders we're going to talk about here in a little bit, which is vesicoureteral reflux. So it's looking at the structures and if there's any reflux occurring. An IVP, or an intravenous pyelogram, is when you use radio-opaque dye that is injected into a peripheral vein and then watch to see how it is filtered out through the urine by the glomeruli. So they take X-rays at frequent intervals, and it's showing the outline of the collecting systems in the kidney and of the ureters as that dye passes through them, giving those structures of those images. Health promotion and risk management concerning the GU system. It is important to take interventions to help prevent the urinary and renal diseases in children. So it's important to be educating parents and caregivers about wiping from front to back when changing diapers, especially of female infants. So using proper hygiene, and especially as girls get older, making sure again that they're wiping from front to back. When we do that, especially when they're first toilet trained, and oftentimes they'll still need reminders even after that. But one of the biggest ways we can prevent UTIs in girls is beginning that education about perineal hygiene from the time that they're first toilet trained. Other reminders to parents: simple ways to prevent UTIs, not allowing children to bathe in bubble baths because it's very irritating and makes for a great medium for growth for bacteria. Teaching parents to recognize abnormally colored urine and seeking treatment for early intervention for UTIs or kidney disease. Making sure that if they are put on a course of antibiotics, that they're finishing that full course of antibiotics to prevent return of infection, especially after a streptococcal infection, because one of the topics we are going to talk about is a complication of a recent streptococcal infection, and not if you don't finish antibiotics, what it can lead to is what's called acute glomerulonephritis. All right, our first topic we're going to talk about with infections of the urinary system and related disorders is urinary tract infections, or UTIs. This should not be a new topic. I mean, you've talked about it in the adult. Really, the treatment is not much different. There's a lot of education that goes into teaching parents about ways to prevent UTIs. But UTIs are pretty common, more often in females than males, and usually too because of the just the anatomy of females is what makes a difference, the anatomic and physical factors. Females have a shorter urethra, and that close proximity of the vagina and the rectum is what leads them easily to spread rectal bacteria and spread it to the urethra. One of the most common causes that we see, most common pathogen, is E. coli. It accounts for about 80% of infections. You can also have healthcare acquired infections, especially children who have urinary catheters, which is why it's so important to make sure we're doing the proper care to prevent those as well. And when we talk about prevention measures, things that we teach parents: changing diapers frequently to reduce infection in infants, girls being taught to wipe from front to back when voiding and defecating. We want to discourage or minimize the use of bubble baths, feminine hygiene sprays, hot tubs. Definitely I would look over that, review additional measures to prevent UTIs that's summarized in box 46.4, because those are just a few to name. Important that when you do have UTIs that they are treated early on, and making sure that they're fully treated, because we want to prevent damage to the bladder lining, and we don't want it to spread to involve the kidneys, which is polynephritis, because that can lead to permanent damage. So again, girls who typically have one UTI should be thoroughly assessed. If they have a second UTI that occurs, we will need to refer them to a pediatric urologist to determine if there is a congenital urologic anomaly like urethral stenosis, or the next disorder we talk about, the vesicoureteral reflux. In males, if they're older than the age of 3 months who present with a UTI, they need to be evaluated as well by a pediatric urologist. Assessment for UTIs in children, especially young children, the signs and symptoms aren't always as clear-cut as they are in the adult. The typical symptoms that occur in the older child or adult may not be present in that younger child. So the typical things that we see: pain on urination, frequency, burning, hematuria. Don't always see that with a young child. UTI needs to be suspected whenever a child has a fever that has no demonstrable cause on a physical exam. And if it is a bladder infection, the signs and symptoms that you're going to see with cystitis, low-grade fever, mild abdominal pain, enuresis or bedwetting. And if it's polynephritis, which meaning that we are involving the kidneys, the symptoms you're going to see are more acute. They have a high fever, they're complaining of abdominal or flank pain, vomiting, and malaise. Oftentimes, young kids will complain about, especially a younger age, because they don't complain necessarily about the things that we think about, the pain on urination, the frequency, the burning. They'll complain about abdominal pain. So you do have to think about with a young child who's complaining about abdominal pain that it could possibly be a UTI. For diagnostic evaluation of UTI, oftentimes we're going to do a urine culture and sensitivity via the suprapubic aspiration, a clean catch, or sterile catheterization. That's going to help us identify the responsible organism. And then we can also look at hematuria, which could be present due to the bacterial irritation of the bladder mucosa. And the pH of the urine will often be elevated greater than 7. So how do we manage UTI? Well, it's an infection, right? So that means they need a broad, and usually they can just do an oral broad spectrum antibiotic like Bactrim or amoxicillin, or an antibiotic that is specific to whatever the causative organism is that's cultured in our diagnostics. We can also use, another good drug of choice is nitrofurantoin. It's a good choice for UTIs. It's a broad spectrum antibiotic that concentrates in the urine, and it can be used both to treat a UTI and also for prophylaxis of UTI. One of the other things we teach them to do is drink large quantities of fluid to flush out the infection in the urinary tract. Water is the best choice. There's kind of an old saying to, whenever you have a UTI, give or drink cranberry juice. Cranberry juice recommended because of the acidifying affects the urine, makes it more resistant to bacterial growth. In actual practice, though, there's very little evidence that it actually works, but the most important thing is to make sure kids are drinking plenty of fluids. Water is best, but any amount of fluid is going to be helpful because that helps to flush things out. You do want to avoid fluids that have artificial coloring and carbonation because that can irritate the bladder and cause further discomfort, which we want to avoid. If they have moderate or severe pain on urination that's interfering with their ability to void, you can suggest having them sit in a bathtub with warm water and just voiding into the water. Parents can use a mild analgesic like acetaminophen to reduce their pain, hopefully enough to allow them to avoid. And make sure we're reminding parents with a UTI, again, complete that full course of antibiotics. They'll often need to do a repeat clean catch urine sample, usually in about 7 days after antibiotic, because we want to make sure that we're clearing up that infection. And if it's indicated for some children who have had multiple recurrent UTIs, then they'll often put them on prophylactic, not recurrent, but prophylactic antibiotics for 6 months while they take measures to optimize voiding habits, hydration, or if there ends up being a structural issue, giving them time either to mature and grow out of it, or if there's surgical correction that may need to take place. So that's getting into like the vesicoureteral reflux, which we will talk about next. Our next topic we're going to talk about is vesicoureteral reflux, or VUR, and it is retrograde flow of urine from the bladder into the ureters. So looking at this picture I have on the slide, the one side is just showing normal flow of urine should be down from the kidneys into the bladder, but unfortunately with vesicoureteral reflux, what happens is we often have urine that's coming from the bladder back up towards the kidneys and sometimes into the kidneys, depending on the grade of the reflux. And when we have that reflux, it ends up causing inflammation, irritation, and it can cause damage and scarring to that ureter as well. So reflux of the urine occurs with voiding when the bladder contracts because the valve that guards against the entrance from the bladder to the ureter is defective. And that could be from birth. It could be because of scarring from repeated UTIs. Maybe the bladder pressure is stronger than usual. Or it could be because ureters are implanted at unusual angles. Maybe it's too low on the bladder wall. So they've kind of got these oblique angles that's allowing the reflux to occur. Reflux has the potential to lead to bladder infections. So urine that's retained in the ureters after voiding then drains back into the bladder after the child finishes voiding, where it remains. You have stasis of any fluid that's subject to infection, which leads to decreased ability for normal bladder tissue to lyse the bacteria. And that's just because of the large residual volume that's always present. On assessment, again, they often have they do have a history of repeated UTIs. When we talk about diagnostics, this is where we'll do that VCUG, the voiding cystourethrogram x-ray study. We can do a CT scan, MRI. We can do cystoscopy or cystography with contrast. Things to basically go in and look at the structures of the bladder, see if, in the the ureters, and then of course seeing if they are refluxing. And based on those different diagnostic studies, then we'll grade the reflux on a 1 to 5 degree. Grade 5 is being the most serious, which means the higher. So the higher the degree, the higher and the worse off the reflux is. We talk about therapeutic management for vesicoureteral reflux. The majority will resolve with maturity without any need for surgery. But sometimes until growth can occur, we have to treat the condition to reduce the possibility of glomerular scarring from infection or the back pressure. So we often teach them to do what's called double voiding, meaning making sure the child really empties. So they try and void once, and before they actually get up, having them try and void again to make sure in between that urine that's refluxed up into the ureters has time to go back to the bladder so that they can fully empty and not have urinary stasis. Sometimes they do have to remain on prophylactic antibiotics for a lengthy amount of time, and that's just to prevent the bladder infection from reoccurring. If they are on continuous antibiotics, it doesn't prevent recurrent UTIs or reflux. I'm sorry, let me rephrase that. If continuous antibiotics don't prevent the recurrent UTIs or reflux is severe, then we start looking at doing surgical correction, and we can correct that with cystoscopy. They can also use an injection of what's called deflux, and that can stabilize the ureter valves. And sometimes we just need to correct the implantation sites. So we can do laparoscopic surgery to reinsert the ureters at a more oblique angle to decrease the or get rid of the chance of the fact that they're refluxing. So it just depends on what the actual issue is as to why they're having the vesicoureteral reflux. If they do, the rest of this is primarily aimed at surgical correction. So I'll talk about that in the next little bit. Right. So if they have surgical correction of the implantation sites of the ureters, it could be one-sided or it could be both sides. It could be unilateral or bilateral. And after surgery, they do have a lot of different tubes and catheters coming out, so it's important preoperatively to explain what those tubes, how many there will be, all the different stents and tubes that they will have, how long they'll be in place, and how to care for those. And we'll get into that in just a minute. But after surgery, they have a suprapubic catheter that does remain in place to keep the bladder empty and to prevent pressure against the surgical area. They'll also have 2 urethral catheters or stents into the ureters to drain urine directly from the kidney pelvis. And then all 3 catheters are usually attached to some sort of closed drainage system. There's sterile gauze dressings and an antibiotic cream that's placed around the tube insertion site just to help keep it free of infection. So again, it's important to prepare not only the child, but especially the child and the family for surgery and what post-op care will look like. So explaining again the number of stents that they'll have, explain that even with the tubes in place, the child is still able to get up and allowed to walk and move about, and we want them up and moving around as soon as possible, just like any other surgery. But making sure that if family is getting them up, and they are allowed to get them up, that they make sure they don't raise those collection systems above the child's level, bladder level, when helping them get out of bed. So making sure we're keeping them low so we don't have basically urine backflow. And also with post-op care, urine will drain primarily from the kidney stents for approximately the first 3 days after surgery, and then therefore after will drain mainly from the suprapubic tube. It's important to assess those stents that they're draining to ensure kidney production is equal on both sides. Observe the suprapubic tube and the stent drainage closely for color or for clots, and measure the amount recorded, and usually do Q 1 hour times 24 hours and then every 4 hours, or per the physician orders. The initial drainage that is coming out from any of these tubes, wherever that's coming from, the initial drainage will be bloody, and that's normal. That should clear in 2 to 3 days. The stents are usually removed before discharge, and one of the other issues that you have post-operatively is the incisional pain and painful bladder spasms. Those can be present for the first 3 days after surgery. It's important when you're thinking about pain management that you're assessing for bladder spasms, not just incisional pain. And in order to combat those bladder spasms, we often will give them the antispasmodic. The drug of choice that I usually see in practice is ditropan, is usually prescribed to reduce those bladder spasms. That suprapubic tube will usually be removed in 4 to 7 days after surgery. When it is removed, it can have a little bit of urine leakage from the puncture site for a day or two. Just important to keep a sterile dressing in place to absorb the leaking urine, and making sure family understands to avoid tub baths until that site has completely closed, because we want to reduce the risk for infection. All children will need follow-up care. They oftentimes will need a repeated VCUG and or an ultrasound to establish that the surgery was effective. So with the voiding cystourethrogram is looking at the structures of the ureters and the bladder and the kidneys, and looking to see if any reflux is present. Well, if we did the surgery and everything was successful, we shouldn't see any more reflux occurring. So oftentimes they'll do a repeated either VCUG or ultrasound to make sure everything looks okay and we're not having any more reflux, and we really truly fixed the problem. All right, enuresis is the disorder we're going to talk about. This is a disorder affecting normal urinary elimination. Enuresis is just involuntary passage of urine past the age when bladder control should have been expected. So usually that's 2 to 3 years of age during daytime and age 4 to 6 years for nighttime. So usually we consider they have enuresis at occurring approximately at 7 years of age. It could be nocturnal, diurnal, or both, but most of the time it is nocturnal. And you can have primary or secondary enuresis. Primary is if bladder training was never achieved, and secondary is if control was established, so meaning you have potty training, but it's now been lost. You have enuresis is more common in boys than it is in girls, and it tends to be familial. Assessment-wise, they have to have the developmental age of more than 5 years of age. So even if chronologically they are older, but their developmental age is not matching their chronological age, developmentally they have to be at age of 5 years or more. And we'll need to do an evaluation to determine if there is an organic cause, something else that we can fix. When you think about therapeutic management, it depends too how much, if is it stress factors that are affecting it, and if so, identifying what those factors are and helping the child to cope with those stressors. One of the big things we can teach families to do and child to do is fluid restriction in the evenings, 2 hours before bedtime. It just reduces the chance that they will have enuresis. It is important with a child who has sickle cell anemia that you're not restricting fluid, because we worry about dehydration. We know, as we've already talked about, dehydration with sickle cell anemia can precipitate a sickling crisis. We can also use what's called conditioned reflex response devices, which it doesn't really stop the bedwetting itself, but the idea is if you've got a kid who's like maybe a sound sleeper, who's just not getting that message like, hey, bladder's full, you need to go to the bathroom, you can put a sensor on that registers the wetness. You can either oftentimes clip it to either their underwear or like a pad that's on their bed, and as soon as it senses the wetness, it alarms and wakes up the child, and then the idea is that the child will stop voiding and gets up and goes to the bathroom. So it's kind of what they call a conditioned response, and learning how to get that wake up for that signal like, hey, you got to go to the bathroom. We can also do, which is contraindicated, but sometimes they can do what's called bladder stretching exercises. It's really contraindicated. It's not really fixing the issue, but sometimes you will hear about bladder stretching exercises. When it gets into drugs, there is one drug that we actually do use for enuresis, but we usually try, non-pharmacologic type management first. And the drug of choice that we use is desmopressin, or DDAVP. We talked about this before, but we talked about it with hemophilia. It actually also ends up having another effect. It reduces urinary output in enuresis. So not only does it help with the cause or their issue with hemophilia and stimulating factor VIII release, it also has the other effect of reducing urinary output. And by reducing urinary output, the idea is that we reduce enuresis. As a general rule, try not to put a lot of stress and importance on the enuresis during illness and encourage parents to do the same, because enuresis can occur in a hospitalized child just because the stresses of a new environment, being sick, that is normal for them to have a little bit of regression with potty training oftentimes. All right, our next two topics that we're going to talk about, and the last ones we talked about for GU, I highly recommend using the Venn diagram that I attached with your notes. It's the two overlapping circles. Make one of those circles for acute glomerulonephritis and one for nephrotic syndrome. What goes in the center where they're overlapping are the commonalities between the two, because the two syndromes, acute glomerulonephritis and nephrotic syndrome that we're going to finish talking about, have a lot of commonalities. So if you know what's common, start again looking at the things that make them different. So for those of you who are visual people and who like to rewrite information, that might be a useful tool for you. So let's talk about acute post-streptococcal glomerulonephritis. It is inflammation of the glomeruli of the kidney, and it follows a streptococcal infection. Now remember, a streptococcal infection can be from having strep throat, which is what we typically think of, but what also causes streptococcal infections? What about impetigo? Right? Remember back to integumentary. These are one of the complications that we can see if we don't completely take care of finishing antibiotics for streptococcal infections. So it follows a recent streptococcal infection. The pathophysiology, what ends up happening is the glomeruli, the down and dirty of it is the glomeruli infiltration occurs backing up. There's intravascular coagulation at the minute renal vessels, which leads to ischemic damage, which leads to scarring, which leads to decreased glomerular filtration or function. The glomerular filtration, this is the down and dirty of it, you have decreased glomerular filtration, which leads to accumulation of sodium and H2O in the bloodstream. Very important. Accumulation of sodium and H2O. So you have inflammation of the glomeruli, which leads to protein molecules escaping into the urine. Again, another really important piece. This is what's going to see. We're going to see these kind of things with our clinical manifestations that I'll talk about here in just a little bit. Assessment-wise, most common in children 5 to 10 years of age. Why is that? They're the group who tend to get the strep infections more commonly. More common in boys, and it's more often in winter and spring. And again, typically the child has a history of a recent respiratory infection, 7 to 14 days prior, or like impetigo. Again, remember both of those being recent streptococcal infections. So impetigo being within 3 weeks. Your clinical manifestations that are present with acute glomerulonephritis, they have a sudden onset of hematuria and proteinuria. So blood in the urine and protein in the urine. The protein is a non-specific protein loss. The urine, because of the blood in the urine often appears tea-colored. You'll also, after those initial urine changes, the child will develop olguria. What's olguria mean? Meaning low or little urine output. Their specific gravity is increased. And then for your next two blanks, what happens is a result of that accumulating sodium and H2O in the bloodstream. So you have to understand, where is our fluid hanging out? With acute glomerulonephritis, it's hanging out in our blood system, in our circulation, in our cardiovascular. Because it's hanging out and we've got too much and we can't get rid of it because we're not filtering, it leads to hypertension. So for your blanks, right under specific gravity, hypertension from hypervolemia. We have too much fluid in our circulatory system, so circulatory overload. All right. They can also have abdominal pain, a low-grade fever. Why would they have a low-grade fever? It's because we have a post-streptococcal infection. So there could still be some streptococcal organisms present in the body causing that low-grade fever. They have edema. They have edema because we're hanging on to sodium and water. It's just a matter of where we're hanging on to it. But overall, they're going to have some edema. Because it's in the circulatory system is why we get into cardiac involvement. So look at all those signs and symptoms of cardiac involvement. Gets into even possibly heart failure, right? Too much fluid, hypervolemia. They can have anorexia, vomiting, headache, are all signs and symptoms that we can see. We talk about the diagnostics. They have hypoalbuminemia. They have hypoalbuminemia because they have a lowered blood protein level due to that massive proteinuria, the massive protein loss in the urine. You'll see mild anemia because of the expanding blood volume. Basically, we're diluting everything because we have hypervolemia. So they end up with mild anemia. Again, because of the expanding blood volume. Their ESR, so elevated SED rate. Why is there elevated SED rate? It's high. Sorry, I kind of gave it away. Why is it high? It's because of all the inflammation that's occurring back with the glomeruli. Their BUN and creatinine, what do you think that's going to be like? If we're not filtering, what's BUN and creatinine going to look like? It's going to be elevated. It's elevated because, again, we're not filtering, we're not functioning like we should be. And BUN and creatinine are direct indicators of how well those kidneys are functioning. Our therapeutic management for a child with acute glomerulonephritis. In most children, it's a pretty limited, short-term, maybe 1 to 2 week benign course. Most times, again, it's just a one and done. They usually don't have repeated episodes of this. And there's very little specific therapy other than it's about alleviating symptoms. One of the big ones that they need, antibiotics. Why do they need antibiotics? Because again, this is a complication of a recent post-streptococcal infection. Most likely, they probably didn't finish their original treatment, the antibiotics, for that streptococcal infection. So we need to give antibiotics to make sure we rid the body of any streptococcal infection. Why are diuretics of little value? Well, if we're not filtering, diuretics aren't going to help us. If the glomeruli are infiltrated and they can't filter, we can't make urine. Well, we can make urine, but we can't get rid of that urine. And think about where it's hanging out. It's hanging out in the circulatory system. Diuretics aren't going to do us any good. So oftentimes, you can't give diuretics until you've fixed the issue with the glomeruli being inflamed. Once you start to fix the inflammation that's present, we'll start filtering and getting rid of the excess fluid that we have. If we do have heart failure that occurs, you got to think about the things that you would do for heart failure. Put them in a semi-Fowler's position. We can digitize them, meaning give them digoxin to make sure that their heart is pumping effectively. May need oxygen administration. Those are just to name a few. One of the other big things is, remember, where's all our fluid sitting? It's sitting in the bloodstream. So again, we're hypervolemic, so we need to get rid of that. And again, because we're hypervolemic, we have leading to hypertension because we've got too much fluid. So oftentimes these kids need hypertensive medications. This is one of the big things that sets it apart from nephrotic syndrome as well as the hematuria. You don't see hematuria in nephrotic syndrome, so this will be something that sets it apart. And the antibiotics too. So again, thinking about because of the heart failure, because of the too much fluid causing the problems, too much fluid in the circulatory system, we're going to need antihypertensives, and we need to do different heart failure nursing care measures. Our drug of choice is often labetalol in order to manage their hypertension. One of the other big things that we need to do is diet. They need a regular diet. We do need to put them on a fluid restriction during that hypertension and edema phase. We certainly don't need to add to it because we know that sodium is going to attract water, which will just further enhance the hypervolemia that we have. We need to do potassium restriction as well during the olguria phase because foods that have a substantial amount of potassium are generally restricted when we have periods of olguria. Why? We're not filtering. So if we're not filtering, we're not getting rid of that. If we add to it, it just gets us into further cardiac issues. We also need to make sure we're weighing them daily and calculating their I&O. That's going to give us an important assessment, help us follow their course and extent of the disease, because it's going to allow us to know, how, are we gaining fluids? Are we getting rid of some of that fluids? Is what we're doing working or not? So weighing daily, because that's a good measurement of how much fluid are we hanging on to? Are we gaining? Or are we starting to lose? Right? And again, monitoring how much is going in, how much is coming out, especially as we start to fix that filtration issue. Bed rest, not necessary, but we do want to encourage some quiet activities rather than active exercise. And they can usually return to school in 1 to 2 weeks. In 1 to 2 weeks, and engage in typical activities. However, competitive activities are usually limited until kidney function has fully returned to normal, and that can take up to 2 months. 2 months of time. All right, our last topic is nephrotic syndrome or nephrosis. And what's happening with this one is we have altered glomeruli permeability. So instead of issues with filtration, this time we're super permeable. They have the altered glomeruli permeability because of an autoimmune process or a T lymphocyte dysfunction. And that ends up resulting in fusion of the glomeruli membrane surfaces, which leads to the abnormal loss of protein in urine. So they're losing a lot of protein in urine again. Peak incidence is at 3 years of age and happens more often in boys than girls. There are a couple different types of nephrotic syndrome. There's 3 different forms that we can see. Not as worried about you knowing that as about understanding what is happening, what the changes in the nephrotic syndrome look like, and what those symptoms are. But the 3 forms are congenital nephrotic syndrome, which can be from an autosomal recessive disorder. They can have secondary nephrotic syndrome, or they can have idiopathic nephrosis. Idiopathic nephrosis is the most common that we see. The 4 characteristic symptoms that we see with nephrotic syndrome: they have proteinuria. They have a massive urinary protein loss. They have edema. Edema is everywhere in their body. And again, it's going to be a matter of where those fluids are hanging out in nephrotic syndrome that will set it apart from the acute glomerulonephritis. They also have hypoalbuminemia, which meaning low serum albumin levels, so low blood protein levels, and they have hyperlipidemia, which is increased blood lipid levels. So the chart in your notes, the one that goes, can be autoimmune process, which leads to your increased glomeruli permeability, which leads to increased albumin in their urine, which leads to hypoalbuminemia. You have edema present, and then hyperlipidemia present. It's kind of just a lovely little snapshot of what's happening. But to further explain those changes and those 4 characteristics, what's happening is you have increased glomeruli permeability, which leads to that protein loss in the urine, and again leads to your hypoalbuminemia. Because you have low levels of protein in your bloodstream, what happens is there's an osmotic pressure shift that causes fluid to shift from the bloodstream to interstitial tissues, which leads to your edema that's kind of overall in the body. So again, you have to think about, where's our fluid sitting. With nephrotic syndrome, it's not in the bloodstream anymore. It's interstitial tissue. So then what happens is we end up with hypovolemia, because as that blood volume decreases, the kidneys begin to conserve, and they're conserving sodium and H2O or water, which then just adds to your potential of edema. So we're kind of getting in this vicious cycle, right? And again, because all that fluid is, because of the osmotic pressure shift, it's sitting in interstitial fluids. It's not in our blood circulation. So because of that, one of the things we will see, one of the big ones, is ascites. We still have edema everywhere, but ascites especially. As well as the last one, hyperlipidemia. How do we get to hyperlipidemia? How does that even make sense? Well, what happens is the body tries to compensate for all that protein loss. So what happens is the hyperlipidemia occurs because the liver increases the production of the lipoproteins to compensate for your protein loss. However, those lipids are too large to be lost in the urine, so then our level rises high in the bloodstream or in the blood serum, which gets us to the hyperlipidemia. Assessment-wise, what are you going to see? Signs and symptoms in these kids. Symptoms tend to begin more insidiously with these kids. They have edema. Edema everywhere because, again, where is all this fluid sitting? It's sitting in the interstitial fluids. So it tends to be dependent. It occurs in the lower parts of the body, and especially, in the morning when they first get up, they might have a lot of periorbital edema, again, especially in the morning, but once they're up and moving, what happens? Gravity takes over. It tends to be in the lower parts, so that periorbital edema gets less as the day goes on because they're up, they're moving around. Their skin becomes pale, stretched, and taut because of all that edema. They can have scrotal edema, which is extremely marked. I already talked about the periorbital edema. They have ascites. That ascites is putting pressure on the stomach and the intestines, which then leads to anorexia, vomiting, diarrhea. Because of that, they get into poor nutrition. Because of the poor nutrition, they don't feel like eating. They just don't feel good. We're not taking in enough. We start to see a growth decline and even getting into a malnourished. Although oftentimes they don't look malnourished, they look obese. And it's just because the amount of edema that's present. The abdominal ascites can press even against the diaphragm if it's so severe, which can then get into difficulty with breathing. In general, they're irritable and they're fussy. You probably would pee too if you had all this edema all over your body. And they just they have this feeling of fullness and generalized edema. They're at greater risk for clotting because of the decreased intravascular fluid volume. Again, hypovolemia. What I like about this picture is it's showing some of the edema that you see, the ascites in the one picture, and then of course the periorbital edema. It's just to give you some examples. But I'm also going to talk about diagnostics. For these kids, our diagnostics, we're going to look at the protein urea, and it's again usually 1+ to 4+, no different than what you have in acute glomerulonephritis, because again the protein loss is almost entirely albumin. Their ESR is elevated, same as acute glomerulonephritis. Their serum protein is low, so hypoalbuminemia. No different than acute glomerulonephritis. BUN and creatinine are elevated. It's not functioning. Kidney function isn't like it's supposed to be. Lipid levels are elevated. That is different from acute glomerulonephritis. Their lipid levels are so high because remember, the body's trying to compensate and it produces these lipoproteins, but they're too large to be passed in the urine, so it stays in the bloodstream, which is why we get those high lipid levels. We can also do an MRI or a renal biopsy can be done as well for diagnostics. All right, and our last part, therapeutic management. Therapy for nephrotic syndrome is aimed and directed at reducing the proteinuria and the edema that's present. How do we do that? We got to use a course of corticosteroids. The course of corticosteroids oftentimes will use IV methylprednisolone or PO prednisone. And when you're on these corticosteroids, they're on them usually kind of long term, and that we know, unfortunately, a side effect of being on corticosteroids for long term is it affects our immune system. There's a suppression of the immune system. So it's really important to keep these kids free of infection. Don't worry about the initial dosage. I just want you to understand they need to be on course of corticosteroids. And knowing that long-term side effects of corticosteroids, you can see those listed there as well. Again, we've got too much fluid in the body, so the obvious choice is why not use diuretics, right? Well, again, you got to think about where's the fluids at. Diuretics aren't commonly used to reduce the edema of the nephrosis, and that's because they tend to decrease the blood volume, which is already reduced. We already have hypovolemia. If you gave a diuretic, we're not getting rid of that fluid that's in the interstitial tissues. It won't work. You've got to create the osmotic pressure shift in order to get the fluids back into the circulatory system. Children who respond poorly to prednisone alone, then they may use the diuretic therapy like Lasix just to initiate more kidney function. If they are getting a diuretic, or when we create that osmotic pressure shift where the fluid goes from the interstitial fluids back into circulatory, again, you may need diuretics, but initially it's not going to help. You're just going to lower your blood volume level with diuretics. So until you get the fluid shifting back into circulatory, oftentimes you're not going to do Lasix, which is usually the drug of choice. If you are doing Lasix, again, it's to initiate more kidney function. You do have to make sure you're using a potassium supplement, because we know that Lasix is a potassium wasting diuretic. So you would either need to do potassium supplement or encouraging them to eat high foods in potassium, such as bananas and milk. You may also want to review that table 46.4 for foods high in potassium. One of the other ways that we can also correct the hypoalbuminemia that's occurring is give them an albumin infusion. It causes the edema to decrease because the serum albumin level rises, which fluid shifts from these sub-Q or interstitial spaces into the bloodstream. So you're getting that fluid back into the circulatory system. When we do that, again, that's when we need that rapid-acting diuretics, oftentimes Lasix, because now you've got too much extra fluid in the bloodstream and it needs to be removed, and we can do that with a diuretic. Important with the diuretic that it's administered after infusion, or the child could end up developing a fluid overload and getting into fluid overload, subsequently heart failure. If the other things don't work, they can also do immunosuppressant therapy, or if they're not responding to the steroids, they can do immunosuppressant therapy, oftentimes cytotoxin, but they often have frequent relapses, or they can do it either because they're not responding to steroids, they have frequent relapses, or they're having side effects that are threatening their growth and development. One of the other big things that sets this one apart from glomerulonephritis is the type of diet that they need. With nephrotic syndrome, they need to have salt restrictions when they have large amounts of edema present. So oftentimes they tell them regular diet, just no added salt. They may put them on a true salt restriction diet, like meaning you can only have so much sodium per day. But understanding that with acute glomerulonephritis, regular diet, with nephrotic syndrome, we need a salt restricted diet. And your very last page of notes, page 11, just another, if you don't want to do the Venn diagram, here's another table that you can review straight from the book. It's table 46.3. I've left it blank on purpose so that you can fill it in, those who like to write, and then you've got a nice side-by-side comparison of those things as well. So you can go through and fill that out.